for joining today to the February edition of AI for Health. Today we have two speakers. The first one you're going to hear from is Reza Forghani, who's an MD PhD in molecular and cell biology. He completed his diagnostic radiology residency at McGill. He has a clinical practice at the MUHC and directs the Augmented Intelligence and Precision Health Laboratory there. His main interests are artificial intelligence applications in healthcare and advanced imaging applications. So without further ado.
Thank you, Joseph. Thank you for the invitation to speak. Bonjour tout le monde. Juste pour que ça soit le plus clair possible, je vais faire la présentation en anglais. Je pense que ça va être pour le mieux de tout le monde. Mais je parle un peu français, alors je voulais commencer comme ça. So thank you again. First, it's great to be at UDEM. It's needless to say, Shum and UDEM lead in AI. So we are all aware of that, and congratulations to you and for doing that and keeping that lead. So I will speak to you about some AI applications in healthcare. And I thought what I would focus on, I don't know what is your background, but I thought maybe I should actually start talking some about imaging, because I started my PhD in a very basic lab doing molecular and cell biology. And even when we thought about omics, we thought a lot of things, and images were not necessarily there. And maybe by the end of this, I can convince you why maybe you should think of images a little more if you don't already. And then how about integrate some of these things together? Just in terms of disclosures, I'm not going to be talking about any industry-specific things, but I should let you know of my conflicts of interest. And this is really the outline. So let's start with medical imaging and patient care. So I'm sure you have heard a lot about radiologists, and actually, if you go by the French press, maybe not doing always good things, and that's okay, actually, you know what? So maybe you'll see a different side of it, and I can't even say it's not all deserved, by the way. So this is a CAT scan of a patient with tongue cancer. So one of the things, despite, there's a lot of things you hear about imaging, and I'm not saying this because I'm a radiologist, imaging has changed the way we do things. If you go 40, 50 years back, how did they diagnose? They did an X-ray. They essentially didn't know where they're going. 30% of appendices that were taken out were negative because people didn't have a good objective way of quantifying disease. And imaging has completely changed that, right? We can see inside the body in ways we never could. So it's fair to say that imaging is at the center of most major diagnoses. I'll talk a lot about oncology, but it doesn't have to be limited to oncology. So in oncology, for example, if you take a head and neck cancer, when someone has something like in the mouth or somewhere in the throat, imaging plays a major role to tell the surgeon where does the tumor go. And this is not a minor thing. Imagine all the things you value, tasting, speaking. This is all high value real estate in a very small area. And where a tumor goes can essentially decide, are you treatable? Do you get surgery or you don't get surgery? So some really high stakes stuff. So, a lot of progress if you go back to days where we only looked at x-rays. And actually, for example, I won't talk a lot about it, but we do an advanced type of CT called dual energy computed tomography. It enables you to get a lot more quantitative data that further increase your accuracy. Maybe that's actually partly why I got into AI. I got interested because I also noticed we are wasting a lot of data when we look at things, that there's a lot of information we are not using in routine practice. Or sometimes we don't even know how to use. And things like this, where you can actually map certain materials. This is actually derived from a CT scan. It maps iodine. So maybe these CT scans for cancer, frequently we inject dye, right? Dye goes in blood vessels, right? And this is how we see tumors better. And actually, because of its properties, using certain types of CT scanners, we can map iodine, actually do material decomposition. And again, so lots of interesting data that's available there on images to help diagnosis. Now, despite all of the advances, and we have made a lot of advances, you'll be surprised that most of the assessment that's done when in patients are actually being treated is quite basic. So when I look at the CT scan, a lot of it is qualitative. Now, there's many years of training, right? So there's a lot of processing that goes, but very basic. And quantitatively, very basic. I mean, we use two-dimensional measurements. Imagine all the information I showed you, and in practice, a lot of things are still really based on qualitative assessment and two-dimensional measurements, like size. not even volume in a lot of cases. So as you can imagine, now molecular characteristics are slowly being incorporated into staging systems. Like, so when someone's diagnosed with a cancer, they get staged. That's partly how you decide how they're treated. And if you look at some of the more recent ones, like in head and neck in 2018, when the Joint Committee reviewed their criteria, they started to classifying, but very slow. Still a lot of qualitative assessments. And I cannot imagine that this is the best way to do things, or that we are really utilizing all the rich information we have access to. So this goes into a lot of information being underutilized, which is both an opportunity and a challenge. Now, we should also learn certain lessons. And you see, sometimes the not sexy things are important, especially if you wonder why healthcare is not evolving. For example, why are two-dimensional things so popular? Well, because anyone can do it, right? So you can come up with criteria and you can go almost anywhere. As long as you have the basic tools, everyone can measure. So it's easy to come with standardized things that everyone follows. There's lessons to be learned there. If we have fancy things, we have to make them workable. Or I can tell you people won't use them. It's a sad thing that I see cool stuff all the time at conferences never used. Because no one wanted to do the non-sexy thing is, how do I make this work? So just keep that in mind sometimes when you design it. You don't want to just do that because it may not be as interesting, but it's important if you want your things to be used. Now, next I wanted to sort of get into, so we showed you some images. AI is being used everywhere. And by the way, it's not medicine, right? Anyone who interacts with a web browser has been interacting with AI in one way or another for many years. But you know, in medicine, radiology definitely has garnered a lot of attention. And why is that? I think that one of the easiest answers is we have been digital for a long time. So if you take the McGill system, we start going on to these 6 PACS, right? The picture archiving and communication system. It's the way we view images and we interchange. In the 90s, they started developing these. So in radiology, you essentially have actual electronic digital form data going back many years. And that's one reason it's attractive. Rather than, let's say, going to clinical notes that may be erroneous, may not be legible, the images are there, right? So even if we diagnose them better now, the information that was there. The quality has improved, so there's more information, but there's a lot of digital data available, so it's not a surprise that there's been so much interest in radiology using AI, especially once networks were built that could analyze images so robustly. And I'm sorry if some of this is basic, I just don't know what is the level of, I'm sure the people from all sorts of backgrounds. So here again, if you go, you know, so just an example of, you know, these digits that have been digital for a long time. Now, we alluded to something before. We talked about, you know, we always talk, so here, when I say omics, what do you think? What comes to your mind for omics? Okay, and any specific? You just named them, right? That's in one shot. Genomics, transcriptomics, proteomics, right? Metabolomics. These are all the omics. Do you think of images when you think of omics? No, trying to say no. I mean, I would say that's a common view. Exactly. So one of our ideas, and this is, I think, what's being pushed and pushed, maybe we should look at these as omics. Because there's more and more data coming out that we can predict some of that information by computerized analysis and application of things like deep learning to medical images. You should not take away from this that we're going to replace pathology. I think imaging is going to push its frontier, just like machine learning applied to digital pathology slides is going to push that frontier. But you could get potentially very useful information that can guide management, and sometimes with certain advantages, which I'll try to make evident. So when we talk about omics, so it's a traditional omics, right? So actually, we have a prospective trial where we actually not only have images, we actually have tissue bank. So we're very familiar with this. You know, we are doing, you know, transcriptomics right now, but we are actually planning to do some other types of omics. But what about image extracted features? I'm not arguing, you know what, maybe we should treat this the same way because that's how they are. Now, image extracted, some of this could be things that are derived through, you know, traditional computer science, computer vision literature, you know, in terms of handcrafted or hand engineered. More and more, especially if you have large data sets, you can get features through deep neural networks, right? But the same principles that you do have features there that have potential predictive value. And this is really the whole field of radiomics. Now, the whole field of radiomics, I put texture there because at least in the medical literature, the two are very mixed. But especially if you're more from a computer science background, texture may have a very specific meaning for you. But who wants to debate definitions? I think the bottom line is I think radiomics is a more all-encompassing term for all of the data, all the mineable data available on images. And I do want to encourage people to think more of these as another omics that maybe can be used to predict certain genes, but in the long run actually integrated with other information to predict, because ultimately it's all about patient care pathway, right? And if you are not familiar with the textual radiomics, I think this diagram is probably the simplest way of thinking of things. So if you look at these, okay, I think anyone can take 1 second look, and these are not identical, right? They look different. So these have the same number of gray, black, and white squares within. Now, right now, when I read a CT scan in clinical practice, if I want to do a quantitative analysis, most often what we do is called region of interest analysis. So we draw a circle, we get an attenuation and a standard deviation. That's it. That's what you use when you have questions. Apart from all the issues having sampling bias, heterogeneity, now you can imagine those are obviously going to be identical when you're talking about first order statistical features, right? But then if you get higher order features or deep features that actually are not hand engineered, so they're not expert designed, but they represent other important phenomenon potentially, then these would be distinguishable. And this is the whole idea, is try to extract quantitative parameters from images, and these are pre-existing images. These are scans patients already have that we can then use to guide sort of diagnosis and eventually therapy. And really, so this goes into this whole idea of using omics to, if you want, put a microscope and start predicting certain genes or certain gene sets using image data. I'll talk about our program. I don't want to talk about too many specifics, but I thought I did want to talk about some of the prototypes you're working on and how that relates. So we talked about head and neck cancer, right? And by the way, a lot of things, the major steps when you think of how you build a analytic pipeline is going to be shared, whether you have image features, molecular, you combine them. But obviously, and there will be specifics to a disease. But if you take a disease like head and neck cancer, right? So we talked about that. Right now, depending on where cancer is, what's the risk? A lot of people get their neck cut. They get all the nodes out. And about, let's say 60, 70% of these patients will have negative. It means theoretically they didn't need that extra surgery, which, as you can imagine, is not desirable. Now, this is not bad practice. This has been shown to improve outcome. It's really a 20% risk stratification. So some of the things, for example, we're interested in is using either features from the tumor or to predict a pathologic node that looks normal when I look at it as imaging. So eventually we can tell the surgeon, you know what, don't cut this patient. Or actually analyze the nodes themselves. There should also be a broader lesson because, sometimes you hear people talk about AI in healthcare, they're looking for perfect. First, if you deal with biology, good luck with perfect. So generally, but our practices are not perfect. So to have something useful, and when you design things, I do want you to think about that. It's not perfection you need utility. There are many treatments, like immunotherapy, for which there is no guideline. Toxic treatments, you never know when they work. Very expensive, so you can get the payers interested. And you have to think about that, by the way, because otherwise no one will adopt this technology. Now, I'm going to argue to you that if you had a stratification way, 40% of patients, 40 seems bad, right? 40, who cares? Cares a lot. Those 40% of patients would care and would get everyone's interest. Because right now our criteria are almost zero. So just think about that. It's not perfect. It's just that practice is not perfect. We are trying to improve upon existing practice. So therein lies a lot of opportunities. So if you go in terms of, so we are more generic. So although I'm a neuro and head and neck radiologist, I have more generic interest in AI implementations in healthcare. And if you think, obviously AI is a very big field. So a lot of things I spoke to you so far was really machine learning, subfield of AI. Natural language processing should not be dismissed. Lots of important application, charts, summary, quality, lots of things coming. And of course in surgery, robotics, right? But still, a lot of things we talk about right now, a lot of our effort is towards machine learning. And deep learning is great. Obviously, that was the revolution, very robust for analyzing large data. But I would have to give you another thing. If you're a scientist, and sometimes I understand you want the perfect, if you go for perfect in healthcare, it might be a long time before you get things done. You just can't go with that. So one thing is we rarely only rely on a deep neural network. We employ classic machine learning. We use hand-engineered features because sometimes they perform better at lower numbers. Because you do, and with the medical data sets, sometimes a very valuable data set is going to be very hard to get large. So we are very interested in how much can you actually use other methods to use smaller data sets to predict. Obviously, that has its own challenges, right? Data augmentation doesn't always work, but there are ways around. And that's where we put a lot of our focus, because if you want to wait for the perfect data set, a lot of things that can really impact patients now, you will not touch, and that's not what we want. And really, I told you how we did things. What is our vision in terms of doing like what I just told you about, trying to predict micromets or predict certain molecular endpoints? Is that right now I give a radiology report, you describe a tumor, you give a two-dimensional measurement. Our hope is, in the long term, you're going to incorporate really the image omic data, right? Use an AI engine on, let's say in a radiology report, rather than just giving measurement, you give volume. Maybe you start classifying, right, probability of certain mutations. These things are being done. They're done on a small scale and in small numbers, but they're done by sufficiently varied groups that I'm fairly confident that these are feasible, right? And sometimes you give accuracy, what is the probability? 80%. In a clinical setting, that can be very useful. We are not looking for 100%, right? And probability of treatment response, very important. So these are things we're generally interested in. So if you think about our sort of lab, in terms of how we are we have data science people embedded within the hospital, and of course we work with groups with computer science expertise, but really our focus is more towards the application, right? Because we're not trying to, compete with or be some of the more basic groups. We work with them for sophisticated problems, but we are in the environment, we see the challenges, and I think that's actually an important part, because then we know what is clinically useful and also what are some of the barriers that we'd have to face to take care of these. And if you think of our program, precision oncology and then non-oncology precision medicine, of course, predictive analytics and process quality, a low-hanging fruit in my view. And this we not very strong there. That's not our strength, but something to think about. Just to give you an idea, these are our partners. So I said I'm a head neck radiologist, but if you think the processes I spoke to you about, there's a lot of efficiency there, right? A lot of these are not disease specific. If you put the team to build a certain architecture, the basics will be the same. So as you see, we have head, neck, thoracic surgery like lung cancer, hepatobiliary, rheumatic diseases, and non-oncologic like cardiology. I should add urology there, who recently joined us. And recently we are going a little into pathology and digital pathology slides, so that's becoming of interest. And all of this is sort of towards this integrated care. Now we start talking about imaging, but at the end, it's not really about image data, is patient care pathways, right? So in the long run, we have to look beyond. Forget those silos, how I was trained, you're a radiologist, you're this. This is not, the patients don't care. They just want proper care. And with time, we actually want to break down those barriers. And like we talked, we can use the image extracted features, use molecular data, let's say liquid biopsy, right? Plasma-derived DNA, clinical information, waveform, whatever you want to predict treatment outcome, who will do well in surgery, right? These are things that will be relevant and will be impactful. Just to give you an idea, for our head neck project, we have a collaborative that's both centers contributing within Quebec and outside Quebec in the US. And this is partly to try to achieve models that are generalizable, right? Because that is the major issue with AI. And going back to this model. Now I want to finish the talk sort of in terms of, hopefully this is the audience, I assume you have interest in healthcare. Talk a little about the other things, because there's a lot of other things. And by the way, they're likely more achievable. I love the precision health stuff and oncology, don't get me wrong. But those are, a few years down the road, right? And on top of that, they're going to have regulatory requirements. Like there are a number of steps there. If you go through the whole patient journey, let's say in radiology, you can start, and this is already being done, smart devices, right? Scanner. So at the scanner, you can set up a patient automatically. So maybe the machine can look at we get this very crude image to decide how to scan a patient. So instead of categorizing patient into large, medium, that's how you select dose. You can tailor the dose so people don't get extra dose. These are being done right now, and these are very practical, useful things. Image enhancement, denoising at the scanner, right? And a number of other things are being in that space, actually accelerating scans for the same quality. Issue in Quebec, you have to wait, 2-3 months for an MRI? Is that really good? I don't think so. Not good at all, right? So these are solutions. If you think radiologists, we talked a little about obviously the precision diagnostics, but I would argue maybe some workflow enhancement things. We recently surveyed a company that used NLP to read our report and make an impression. You say, who cares? Actually, you care because we're expensive, right? So you want us to do the high-end work. So instead of us typing and reading impressions, if you use 5 or 10%, then maybe you won't have those backlogs, right? You won't have your scan read delayed. These are the readily achievable things. Things that actually enhance workflow is another area completely separate that we're very interested in. And this is another reason, because there's a lot of hype with AI, and I think these are some of the claims made initially about general AI. I don't know why people who understood AI so well would make those claims. That's another question. If you go with IBM, Watson goes to medical school, but AI doesn't work that way, right? So now the expectations are high, and at some point people are going to tune out, say this is fancy science. It's nice, but it doesn't affect me. So we have one part that's very, trying to come up with these 3, 5, 10-year projects in precision medicine. Another part that actually I think is just as important, do things that help the patient in the next 6 to 12 months. That's what I'm focusing on right now. And it could be something as simple as help the scheduling, because the scheduling in the hospital is horrible. You have a radiologist talking with the administrative assistant. Like, who would design a system? Like, you have to access a CEO every time you make a decision. Like, it makes no sense. But that's your healthcare system. This is why you pick up the phone and you wait 4 hours, right, to get a scan. Unacceptable. But these are things that are very easily fixable. Actually, I think as exciting. Of course, in the long run, extracting information from EMR. Again, we talk about lost data on image. It's not possible to have for someone to process all the information in an electronic health record. It's too much. There are probably associations there we're not making. So that's a great opportunity in terms of mixing NLP with image features, with molecular, right? That's where it goes. And things we talked about, clinical decision support, should you do a scan or not? Protocoling, scheduling, ordering, things that will impact in the short term. Now, and this is brief talk, very general. We talked about all the good things we can do, definitely some major challenges, right? And I probably don't need to say that to this. I actually assume this audience knows AI. Obviously, technical variations and reproducibility, not insurmountable, but challenges. So when I'm trying to make a 30,000 data set of head and neck cancer, there's a reason. We want generalizable, right? So that's one way. Large and varied, right? We actually have some studies right now on validation, what's the best way, which is also key to future certification. If you know how do you certify an AI algorithm, actually the current CAD system way probably doesn't work well for AI. It wasn't designed for that. It was designed for one diagnosis. So we have to sort these out, and I think these are best sorted out by understanding what's the best way to validate and test things. Nowadays, obviously data sharing, ethics, and privacy issues. Some of these, in my view, are overblown. Personally, I have very small kids. You know what I worry about? In 10 years, what they're going to put on Facebook. I'm serious. I'm not as worried about their scanner, but they're valid concerns that we have to address. And we have to convince the population, or they become barriers. And there are already barriers in some places. Unfortunately, in my view, maybe it's a communication thing. Because people think, like the machines are going to rise and take over us. I mean, unfortunately, that's how a lot of people see this. Whether you laugh, but people are afraid of this technology. And that has to, maybe we need more engagement. And of course, legal and regulatory, who's responsible, how do you regulate, there's a whole other world. That's why some of the workflow things are so attractive. They don't have a lot of this baggage, and we can show some wins. So if anyone's interested. And last thing, I know it's not sexy, practicality. I think that's where our working with the scientists works. The barriers that prevent your family from getting good care sometimes are the most idiotic. I can barely stand them, and I'm a beneficiary of this system. You need to be inside to be able to overcome that. Some of us are interested in breaking this system, and I can tell you I welcome, because my kids are going to need healthcare. Our system needs to be shaken up. But you need that inside knowledge, or you're going to have blocks. You do the best algorithm. your blocks are going to be some of the dumbest thing you can think. They're not insurmountable, but we need to work, and we actually need to work at overcoming those. If there's one message I can give you, it's at least sexy. My view, probably the most important, because I told you, I see nice things done all the time, never used. I go to radiology conferences, all the fancy stuff, not used, and that's the reason. Data creation remains a major thing, so we are very interested in platforms, ways of sharing, like through cloud. And digital health, actually, AI is just part of digital health. So digital health is the right word. Indeed, I would say probably some of the biggest problems we have are the basic IT and interoperability infrastructure than AI. The nice thing is if we want to solve AI, we'll solve that. So you get a double hit. But some of the problems you have, some of the safety and quality issues in healthcare, it don't even need AI. They just need the proper IT infrastructure. But maybe we can use AI being sexy to push those things. So these are, we talked about. Tool doesn't have to be perfect. Think about processing properly. Responsible use is important, but it should not be used to promote status quo. So I just want to give that we should think of ethics, but not just to do whatever we like. And by the way, it's comfortable doing what I like. So it's actually, you could argue I'm not the brightest one. I should just probably root for it. Think about that, right? So at the end, I know it was a very general talk. I hope you learned a little at least about radiology, what's our interest, some of the ways we see, like from a hospital setting, potential for AI applications, and hopefully some of you are going to come and work in this field and with other physicians to address our problems. Thank you.
Any questions? You can use the mic button on your mic.
Maybe I'll start. So in a context where we suppose that the data is shared and we do have access to some data on which to train a new AI system, you mentioned that we don't need to be perfect to get something that would be usable in the clinic. But for the computer scientists, how do you envision that we can understand what level of perfection is sufficient that what we have in hand is useful?
I think that's where you need the interdisciplinary. Just like for example, there's a whole debate in radiology. Should radiologists code? I would argue not. We should understand AI, but I'll never be as good as like you in coding. It's ridiculous, right? So that's where you need to work. And remember, perfect and reliable, not the same thing. You want to be reliable, but perfect meaning that sometimes, and I did basic sciences, you want a ACA of 0.98. That's where you don't need, because the example that I gave you is a 20% risk stratification. Now, why do I go for that? I think we can beat 20%, right? So, and that's the thing. I think that if we work together in terms of identifying, so it's not every disease, but there are a lot of diseases out there where you can set that benchmark, which is clinically relevant. And then we work with the computer scientists to come with reliable algorithms, but with realistic expectations. Mm-hmm. I don't know if that helps you, but.
Yeah, sure.
Hi. What do you believe to be the main barriers of implementation of management in the health system, implementation of innovation in the health system?
Innovation, probably I will argue, over-conservative. Maybe we just very slow to change. There's reasons for that, because health is very personal. So, you don't want to rush in. But I would say that that's been stretched too far. And it's very comfortable, it's just hard to keep up with everything, right? So it's just comfortable to do whatever you did. I think the idea goes top, and it's emotional. I think you have to address the non-logical things. You have to convince the patients why this is, if you think, look, the pharmaceutical industry always takes a beating, and I have no stakes in pharmaceuticals, so I'm not defending them. But a lot of the other parts of the healthcare system that don't perform don't take the same beating. This is emotional because people trust, and that's not a bad thing. But I think the whole attitude has to be changed. And you need some more, I'll say, transparency in performance. If you knew some of the things I see that don't work, if it was communicated to you in a more concrete way, people would be very upset, and then they would. And of course, you don't want to torch the system, right? I mean, some do that, but I don't think that's necessarily the way. So this is where actually you're right. This is where I think the challenge, even for those of us who want to change, the incentive is not for me to change. It's funny to say. It's not necessarily to do better. You should be upset about that, right? As a patient, as a taxpayer, that the incentives are not there. We always say, and I don't have a good answer for that, but I do think if we make systems more transparent and people start to rely, there's an art, but art is not 80% variation. Sorry to my colleagues, I just don't buy that. If you go to hospital A in Quebec and B, and your treatment is completely different, that's not art, man. You got a problem. We have to accept that, and we have to address that in a way that doesn't completely alienate. I'm probably a little more out there, and I'm trying to be nice right now, right? But, and that's probably why I'm interested in this technology. But I think, again, working from people from inside who know their problems, who are frustrated, and there's a lot of us, right? We're not necessarily represented in the newspaper article. A lot of us want to do better, right? I think I can do well and do a good job. I don't think I need to necessarily benefit from status quo, right? And I also know that I want better care for my mom and my kids. So I think that's what we have to align, and we have to incentivize, and I'll say be practical. Like, traditionally, I was right in medicine. The first time I went for a job, maybe you might think stupid. I didn't even ask the salary. Oh, it's bad to ask. But, we do have to say how much things cost, because if you don't, whatever good thing you develop will not be used. Right? Because there's a whole debate, how do you cost AI? And it may seem bad, but it's not, because if you want the population to benefit, we have to address the practical. So not just be like, oh yeah, I don't want to think of that's dirty. That's not dirty, actually. No, what's dirty is me doing something really cool that only works on my data set and never gets to someone. If you think what would be greater than coming with solutions. But this is very complex. Like I said, these are fundamental problems, but I think data transparency is I'm hopeful that it will open. And some of the other people, and I know people don't like, they get scared, Amazon, Google, they're going to come with a different perspective, and I actually welcome that. I think we need that perspective. But that's controversial, right? People, businesses.
So what are the right incentives that should be put in place here?
The right incentives. Some we have to only talk about privately over a drink. But right incentives is look to perform better. I mean, a lot of times there is no performance incentive, and I think that we could learn from business. Until recently, the way our hospitals were funded, you know how they were funded? You probably would be outraged. So they said, your hospital A, this is how much we give you. Your hospital B, how much we give you. It doesn't matter how good you do. It doesn't even matter how many patients come to you. Now, how does that make sense? If you get double the patients, what are you supposed to do with the same budget? Now, that has actually changed. So a few years ago in Quebec, they started to change. I don't think that changed enough, but that's a very basic. I mean, you can all agree that if you do double the work, your budget should be double. No, I mean, this is like a very basic. I'm telling you, these are the basic, traditional ways that actually have no, and I would say in the ideal sense, centers of excellence show performance, right? And I know some people get nervous. I'm not worried. Look, I eliminate some tasks, I'll make new ones. That's what's supposed to be exciting. I know not everyone thinks that way, so we have to get out of this mentality of just volume and think about performance. There's enough of us, but it's not all. And the voices that you hear are not always it, right? So, but there is. But I think going there, and this goes back, don't be afraid of finances. Actually, go by things that will put real pressure. Those are the ways you'll change things. That you force us to perform. I know those who perform, but a hospital that does well should not be punished, which was the old system. You see more patients because people want to come to you, right? But then you have to run a deficit. How ridiculous is that? Does that even make sense to you? Seriously, did you guys know that's how our system was? You need to get more engaged, right? Get engaged and learn how the system is. And once you expose the ridiculous, I'm quite confident change will come. Non, je comprends, mais peut-être pour le restant. Non, c'est bon. En tout cas, je vais pratiquer mon français parce que j'ai pas toujours l'opportunité. Mais votre question, c'est très complexe. Je vais répondre en français puis en anglais pour ceux qui parlent pas. Actually, that's a very complex question you asked. Very good question. So the question was, you have all these, from what I understood, MRIs. They have a certain diagnosis, if you want qualitative, subjective. And what if you put machines? How does that compare? It's very difficult to answer because first, to measure the performance of the machine, what's going to be your gold standard? It's going to be the expert. So you almost have a chicken and egg thing, right? So it's not easy. Now, in the long run, I would argue that can change because eventually you forget tradition. I don't care what we see, tied to an outcome. Now then, that's when you can answer that. We are far from that. My feeling though, I think when people go, it also freaks out some doctors. I think it's unnecessary. It's hard for me to see, and not because I'm a radiologist, a whole person being replaced. It doesn't work that way. Where I think it could is that it complements us, right? The augmented intelligence. So, so I know the tumor, and there are things I see right away like this that sometimes we want to train the machine is so hard. It's like, because all these things are gone. But the things I don't see well, some of those features we spoke about, I can capture. So you do it, you get the machine to give you a probability of something I can analyze. You combine the two, you do that. That's where I would start. In 10 years, we can start scratching once enough has processed and you tie to outcomes. Because right now, I'm telling you, you have a chicken egg. Actually, picking a gold standard is a problem sometimes. Because if you do medicine, you realize, what's the gold standard for pneumonia on a chest x-ray? It always amuses me when people have algorithm makes a diagnosis. It's just an opacity. That could be atelectasis. That could be a whole bunch of things. You need other information. Sometimes you don't know. So, because a lot of our gold standards are funny to begin with. This is why in the long term, I like to tie it to what really counts, outcome, right? And then it doesn't matter. And then we'll know. Et je ne sais pas si j'ai répondu à votre question. Ouais, okay.
Just real quick, maybe patient-reported outcome measures could be one parameter that could try to get over that dilemma of chicken and egg problem. The patient-reported outcome measures.
That's right, but it's got its own, when you try to get patients reporting, it's very variable and you get your own issues. But so you're right, I think outcome measures are very complex. They should be patient reported. And actually, you said something, I don't know if you realize, is so important to me. So I'm very lucky. I work with surgeons who understand tumor recurrence is not the only bad outcome. Because sometimes we are so aggressive. We do soot treatment. They don't recur, but they're miserable. They can't eat. They can't swallow. I don't want that. You're right, so we should measure that. I'm lucky that I have surgeons who are willing to reduce their surgery because they understand that's not understood. So if we formalize that, that's a very good point. There's going to be formal outcomes like recurrence, death, but you're right. Other things, quality of life, very important. And I actually think machines will make it easy because right now it's such a data problem. It's so much. But with NLP and machines, I think we can mix all of these things and do things that we don't do. That's why everyone talks about replacement. I'm like, there are all these things you're not doing. Let's do those first, then we can worry about replacement. Because this is like a paranoia that doesn't even make sense to me right now.
So if you have, for the same image, multiple labels, how do you deal with training a model that tries to classify based on the image? I mean, if you have multiple labels, then any could be good, right? You just said that.
Okay, so multiple labels can be two things. Sometimes you have multiple labels for different things, but I assume you say for the same thing. So that's a classic problem. So let's say you want to do segmentation or volumetrics. Let's say boundary of a tumor. So it's a challenge, you're right. So you have to take experts. And I would say there's no accepted model, but you take multiple readers. And then I think what we propose, and this hasn't been sorted out, it'll have to be sorted out, is probably average those. But also take real experts, because again, and in some fields of medicine, I don't want to name them, I mean, we did some say you have 60% variation. I'm like, how could that be? That's too much. So typically for me, if I take my colleague from Princess Margaret Hospital, I would expect about 3 to 5% counter variation. And the best we can do is merge. Sometimes though it's interesting. Depends what you do. It doesn't matter. There's actually a lot of data. Weak labeling sometimes works okay. And who knows why, but some of it maybe because things outside the tumor have prediction. But that's a whole other complex field.
Is there some manner of hierarchy in terms of like things that are similar versus things that are not? So maybe like you could use that to help your model, if it predicts something that is not far off, but, not very different? Like, is that something you're looking
Absolutely. It's
into?
actually very important. It's sort of an extension of transfer learning. Actually, we do that. Like, for example, I have different data sets. Some have basic information. Let's say you take a head and neck cancer. We can have 2,000 that we have some. And I have like 100 that have genomic data, like full prospective followed. So one of the things we're trying to do is to make networks that understand the cancer, at least get it to a point where it understands, and then try to use, once it's mature enough, to use almost transfer learning concept. And we'll see how that works. So you are, but I think that's the whole concept of transfer. So it's a very important question. That's right. And that's what we try to leverage. Transfer learning is when so maybe in the most basic sense, like actually someone like Joseph can probably answer that better, but if you look at our current networks that analyze images, these weren't derived on medical images. Now that's a whole other debate. Should they be? So, there were all these images of cats and dogs, but the idea is if you're detecting an edge, does it really matter it's a cat or a tumor? Probably not. So you can start with these network architectures as the initial step, and then you refine it by teaching it things that are more sophisticated. So and then I think you can extend that to another level with what we talked about, is even within a tumor. So right now we're trying to teach something what a head and neck cancer is, and then use our most valued small data set for a very specific target and see if we can improve our accuracy despite the small size. And we are actually interested. We are going to have enough CT images, and maybe working with people like Joseph, people like at Mila, is should we actually have networks that were structured based on a scan? It's not clear to me if there's an advantage. I mean, you might have a view on that. Yeah. Nice answer. Well, thank you once again. Thank you.